Hello there, and greetings from Miami, Florida, Nicholas Children's Health System, which includes the hospital and many ambulatory sites, and I'll be telling you about that shortly. My name is Sharon Larson. I am the Administrative Director for Risk Management, which handles all the claims and insurance as well. And I am also responsible for the Quality and Patient Safety Department, as well as the Infection Prevention and Control. I wanted to, first of all, say thank you for this opportunity to speak at this conference. Even though I'm doing it via video, it's a great opportunity for me, and I really wish I was there. However, you know how work gets in the way and life happens, and unfortunately I was unable to attend in person. I want to share with you a little bit of our story here at Nicholas Children's, and through that I want to share with you some opportunities or some new ways to do healthcare risk management. First of all, let me tell you a little bit about who we are. So the hospital is part of a system. We went to the system and we took the system level approach. Several years ago now, probably about 5-6 years ago, we moved to that level. We had various components of the system and we combined them together. And the reason I'm telling you that is it's a little bit the philosophy that we applied to our risk and quality programs. So it's a children's hospital, which is 309 beds. It's pediatric specific, sorry about that. But specialty is pediatrics, and that's up to the age of 21. But it also includes some adult patients, such as our cardiac patients that had congenital disorders. It's also our foundation, which is really our philanthropy fundraising program and foundation. It's Children's Health Ventures, which is a small small for-profit line, that is has some pediatric and safety products that we sell out there at our local drugstores and department stores. Pediatric Specialists of America, that is our employed physician group. There's about 200, a little over 200 physicians in there. And on staff, we have over 700 physicians on staff. The Miami Children's Health Plan is actually something brand new. It's a pediatric health benefits plan where we are trying to, we will be the payer source and the insurance, but we are trying to combine that with our services so that we can give the best care for the least dollars to our Medicaid program for the state. So our next slide shows us our locations of service. You can see from the very top spot there, or marker on the map, to the very southern one is about 110 miles of area that we cover. We are the only freestanding children's hospital here in South Florida, and so our clinics go all the way up several miles north and then a few miles south in order that we can be where the children are. That is our mission. We have also about ambulatory sites. We have about 11 of those. And at the ambulatory sites, we provide urgent care for children. We provide radiology services, whether that's an MRI and where sedation is needed. We have dentistry services as well as some rehabilitation services. We also have a freestanding ambulatory surgery center over at the Florida International University campus. This slide shows you all of the areas of service that we provide. You can see it's very complex, many specialties and many different services. I just want to mention one on the lower side of the second column, our telehealth services. We also expanded our telehealth services over the past couple of years and are able to consult with pediatric patients and their physicians, whether they're in the islands, whether they're in South America, or they're in the Ukraine. This tells you a little bit more detail. I think I've mentioned most of this, except for we have one of the busiest ERs actually in the country. We have about 86,000 visits last year in our ER, and we're well on our way to that number as well this year. And we also have a transport service. So we have a helicopter and ambulances that we can bring patients in from, whether it's the islands, whether it's other counties or other states. All right, so I wanted to do this slide, and it's a little bit wordy, I understand, but I wanted to really drive home the whole point of our quality and our risk management here and what we've done. And one of the things we identified a few years back is that we had risk management as a separate department from our quality department. And they tended to work in silos. We had really grown the risk management program. We had built relationships with the physicians and with staff and really opened up and improved our transparency. So we had better reporting, we had better information. However, we felt like we were making solutions and doing risk mitigation and taking actions that really weren't long-term. On the other side of that, the quality department needed some development. They had ability to do some metrics and obviously follow metrics, but they hadn't done a lot in performance improvement. And so it was recognized by our leadership that we needed really to combine those two functions. And so on here, just to remind all, the risk management, the purpose of risk management really is to reduce organizational loss. And the purpose of quality improvement is to improve processes and the outcomes of patient care. The leadership started to recognize that obviously if we improve processes and outcomes to the best of our ability, it will lead to reducing organizational loss and vice versa, right? So the patient safety movement was out there, and we started to understand that if we look through the lens of patient safety and really understood that we need to focus on patient-centered care as well as reducing harm, that we were going to achieve both of the needs or purposes of the risk and quality improvement programs. So we decided that instead of working in silos, we wanted to combine these two departments under my authority and really make a team out of this. We also added in our infection prevention and control because so many of their practices are risk-based thinking, as well as improvement and the leading and lagging indicators that comes with quality, and really trying to emphasize that. So we went ahead and combined the two programs and started through combining our resources and combining our focus and our dollars. When we did this, these were some of the initiatives and the programs that we emphasized and we worked on. And it started really with the department alignment and went to a safety alert system. And then we looked at our accreditation and we changed our focus. We went from traditional Joint Commission accreditation and we moved to the DNV and ISO. We looked at focusing on having quality advocates at all levels and in all kind of situations, and I'll tell you more about that as well. And then standardization, obviously. This is a big part of the quality movement, and standardizing care and making sure we have standard work. And our performance improvement, we aligned where we were going with performance improvement, the tools that we used by using Lean and PDCA. And then really want to make a goal towards technology and automation. We wanted to make sure that we used automation so that we could, bypass human behaviors and make sure that we avoid opportunities for mistake and for error. This next slide shows you how we align the departments. And you can see I'm basically in the box in the center there. And above me, at that time, I answered to the General Counsel and the Senior Vice President for Legal Affairs. In other words, she was our attorney and our General Counsel and responsible for the risk management program. Recently, we've added the Senior Vice President of Quality, Dr. Ramesh Sachdeva, who comes from the American Academy of Pediatrics and has also worked at several children's hospitals and is a pediatric intensivist himself, and really look forward to how we align this even better. But for the time, you can see this is how it is in the departments below. We also have, in the gray boxes on the sides, we also have several committees that we use for accountability and also for support and pushing through performance improvement. And really accountability on the data and making sure that we have a forward movement with our performance improvement. One of the things that has probably from the very beginning and probably been the most useful tool, they always say that error is prevented by communication, right? And that's the leading root cause for everything. And so one of the things we wanted to make sure is members of all steps and all levels of this org chart, including some more senior leadership, such as our chief nursing officer, we meet on a regular basis on a Friday. We literally just call a debrief. And we talk through the events of the week and talk through what we're seeing in there and the process errors, making sure that we are constantly bringing those two together and really thinking that through to how we can do things better. So I want to go through just some highlights of different services and highlights of the different activities and those key metrics and key processes that I mentioned on an earlier slide. So safety alert system, this is something brand new to us. We've been slowly developing this over time, but the key parts of the safety alert system are a daily safety call. It's literally a 15-minute call. There's a literal list of departments that have to report. It starts with the big administrative role of nursing for inpatient, then outpatient, and then goes on through ER to our supply chain. And make sure that we talk about any events or any risks that occurred in the last 24 hours, any risks that are occurring in the next 24 hours, making sure that the quality piece of it, right, that the resources are there, that the improvement is made, that we solve the problems. Another aspect of the safety alert system is the stop the line. The stop the line is the Toyota production, the lean production model of literally when you have on a manufacturing line, you're making a car and all of a sudden you see a deficiency with a part or a piece or a process. You can push the button, stop the line. So we have this methodology that we are applying and rolling out so that nursing staff, that care assistants, that lab technician, that a physician can say, hey, wait, there's about to be harm to a patient or harm to a staff member. Let's stop the line. And you see the acronym there, SAFER made possible by you. They know it's very simplistic. Stop the unsafe activity, assess the patient, assess the visitor, assess who's being harmed or has the potential of being harmed. Fix the issue if you can, and if you can't, escalate it, right? Bring it up to senior leadership level and report the safety issue and alert so we can trend and theme and look over time and make sure that we are fixing the process problems that we have. Next slide. So typically in the States, we all have to be accredited if we're going to receive Medicare, Medicaid dollars. And all hospitals and healthcare have to be that. Most people have gone Joint Commission. We made a significant decision to switch away from Joint Commission and switch to DNVGL ISO 9001. And I won't say a lot about it, but the reason we switched is they're very process oriented. And they're not giving you a bunch of regs that you have to follow. They're taking the regs and saying, okay, how can you follow these in your own way? What works best for you and in your setting? And if you read that, you see the say what you do what you say, prove it, improve it. It probably looks familiar. It's the PDSA, so, the Plan, Do, Study Act of Quality Improvement. Patient safety advocacy at all levels. So there's a few things that we've done here. We always try to involve the medical directors in any big projects that we're doing. And I have an example of our sepsis protocol that I'll show you, where our medical director of the ICU was key on this. Quality safety advocates, these are identified typically nursing members in the inpatient care units and the ambulatory urgent care centers. The quality safety advocates will meet weekly with the risk managers and a quality representative. They'll go through any events that happen through the week. It's very similar to the debrief that happens on Fridays, but it's at the unit level and unit-based level. And it does a couple things. One, it holds accountability for improving things, but it also creates awareness, and nurses, if they're administering a medication and they see how an error was made, they're probably the best people to understand and know how they can change and prevent that error from happening to somebody else. And then the risk manager leadership, they are leaders, they are managers, management level, and interact with everybody from CEO to the staff person to the kitchen person. I mean, it's anybody and everybody. And they have specific areas of practice, such as there's a risk manager that handles all our ambulatory sites. so they can gain familiarity and understand processes and what's going on there and have better insight into what they're doing. But they also are building relationships with the practitioners in that area so that the practitioners feel more comfortable speaking up about an error or a potential error. Lean is our process improvement tool. On this slide, you can see a couple of ways that we do that. We try to standardize everything. We're moving towards a standard work environment where everything is done the same way every time by any individual that's performing the practice or the process. On the lower right, we have standardized our problem solving so that we use an A3 form, and you can see that one there. And there's a lot of visual management on that. Visual management is very important to us, that we make sure that something's up there in front of everybody's face as they're doing their business, as they're doing work, or they're doing performance improvement, so that it's quick understanding of what has to happen and at what time. On the left side is what we call our huddle board. All inpatient units and outpatient units and care areas do have a huddle board, and they huddle every morning, talking through what metrics they're watching, what they're monitoring. Any ideas that staff might have, they can put on here on a little post-it, and they can introduce new improvement ideas and work it through the whole process of PDCA. Our next one, here's another area of standardization. We're particularly proud of this one. This is our sepsis, where I mentioned that the medical director is involved. We started this initially trying to prevent sepsis or by early diagnosis of sepsis so that we could apply protocols. And you can see the top right, it'll talk about recognizing sepsis, talks about getting your first bolus in of IV fluids and your antibiotics within 60 minutes of diagnosis, and then evaluation of ongoing care. Our physician worked with us, and we now have this built into our electronic health records so that it's based on vital signs and symptoms that bringing it together are early warning signs. And so our computer system will actually, the minute those things are entered in the computer, our computer system will recognize it and alert the physician, listen, you may need to consider and look at your patient, evaluate them for pending sepsis. And so we can get the antibiotics in, we can get the cultures drawn, everything within that time period. It says 60 minutes up there for the antibiotics, but we've been able to get this down to about 28 minutes, so we're particularly proud of that. In our first test phase in the PICU, so based on early diagnosis of the sepsis, we have decreased our length of stay due to that diagnosis by 5 days in our PICU, as well as decreased our mortality by, even more important, by 60%. So significant improvements just by standardizing and automating as much as we could. We believe in metrics. I mentioned that earlier. So this is our clinical excellence index, and we literally have a clinical excellence index. There's about 55 indicators that measure risk and quality and roll up into one number. And this is fully integrated into our practices, into individual performance and department performance and their annual evaluations. And it is monitored on a monthly basis, department specific, and we really believe in using metrics to drive improvement, not just for accountability and know where you're at, but also know where you want to go and really push for that. Another big thing that has helped us this year is really pushing and promoting on near-miss reporting. So near-miss reporting is literally just that. You know, it's identifying, it's incident reports, it's identifying an event that's about to occur and about to harm a patient. And so bringing that up and pushing that forward so that the information can be aggregated and really looked at on an ongoing basis. So this is particular to our medication safety. That's where we started, but that was also our #1 event or incident report that was reported. So over a year, a little more than a year, we've been working on this, and you can see there 33% of our medication variances are now near-miss reporting. so much better, right? And this is really, this is really the best combination of risk and quality that I know of. We've been able to prevent a lot. You can see the communications both for parents and for staff, and our collaboration with other groups on there. And by doing all of that, we've been able to take the risk events, prevent the loss, right? But also take the quality improvement and really understand where we need to improve and what we need to do to prevent medication errors. All right, our Humpty Dumpty fall prevention protocol is a great example of long-term sustaining standardization. This is something that started in 2005 when Joint Commission, our accreditation agency at the time, requested that we have a fall prevention protocol and some kind of fall assessment. So we obviously have been very familiar with falls in children. I mean, that's just part of their development. So we started to analyze what we could prevent and really look at it that way. And we developed a screening process as well as prevention process. So Q-shift, we look at certain criteria that might change their gait, might change their mentation, things like that, that would change their ability to walk straight and not fall. And so we developed this protocol and have since this time had it statistically validated, and we actually sell very cheaply, but we sell it to other locations. And you can see on that table there, we now are at about 1,300 hospitals internationally. So there's two key elements to this and the prevention. So it's identifying the fall risk. Well, that has to go with our patients, and our little patients go everywhere, right? So we developed the Humpty Dumpty as the kind of visual management, and the logo, obviously it's kid friendly as well. And there's a wristband that the patients we can put on the patient's arms, so that anybody, anywhere. So if you've got a kitchen staff moving trays through a hallway and they see a patient with that and about to go down, they know they need to go help that patient prevent their fall. The other piece of it is working in collaboration with other children's hospitals. We've developed and learned from other people's mistakes, which is a great way to learn, right? And developed information and education on it that we provide both to our staff, but also to our parents, because so often, right, grandma or grandpa or mom or dad is walking with their child and hanging out with them while they're in the hospital. So another good example, and I wanted to specifically talk about on this one, is the central line associated bloodstream infections. Obviously, it's about preventing central line. And there's a lot of literature and a lot of resources out there about preventing healthcare associated conditions. This is probably the first one besides surgical site infections that we worked on. And a couple of things I want to point out is, so you see that I have a central line. That is actually information that, again, is visual management and alerting, so that if you have somebody comes in from radiology, they're going to move the patient and turn the patient to put the x-ray behind them, then they are aware that there's a central line and that they need to be careful that they don't pull it out when they're turning the patient. On the right side, you can see our checklisting. We've used a lot of crew resource management and checklisting to make sure we standardize care and how it's done. This one, obviously, the sooner you can move up your prevention or protection up the line of the process, meaning we make sure that we do oral care on our oncology patients, so that and bathing, so that we can prevent the mucal barrier entrance of a bug into the bloodstream. Or we make sure that we standardize and we do sterile, basically dressing changes, so that we prevent introducing a bug into the bloodstream at that time. And we try to standardize and we try to monitor the compliance of that bundle, prevention bundle, rather than waiting for the outcomes and looking at the metrics in that way. Technology. I mentioned we're big into technology and automating, and obviously it's a great risk management tool because you can prevent mistakes from happening, and the more you can hardwire. But you can also use it to take work time and stress off of staff. So you see on the far right there, we have an app that says CPR, but it's our virtual reality clinic basically. And it allows our staff and our users to practice clinical techniques. We're rolling this out to family members. With chronic children that taking home, a family member might be responsible to responding to a seizure or responding to respiratory problems or resuscitation. And so we can teach them how to do it through this virtual clinic. We can assess and we can keep up with them after discharge to make sure they're comfortable with what they're doing. We also have apps for portals for information for parents, and we have workflow automation and information management solutions that we've been trying to do so that we can streamline and always try to build in hard stops wherever possible. So I know that's a lot of information and it's our story, but I hope that you can understand and see how key it is and how important it is to have teamwork between our quality improvement experts, between our risk management team, sharing of data between all, sharing of focuses, sharing of responsibility and resources, and how that will lead to better patient safety. Once again, I really appreciate this opportunity to talk to you and to speak, even though it's through video. I hope you have a great conference.